Good evening, friends. Let's welcome you all to this another important session of 46th Comprehensive Course on Echocardiography. We have with us Dr. S.K. Parashar, sir, who is the past president of Indian Academy of Echocardiography, Cardiological Society of India. And on top of that, the most learned man in echocardiography in India. Many of us, including me, have learned many things from him. We call him as a Bhishma Pitamaha of echocardiography in India. With these few words, let me hand over mic to him to start his deliberation on common cyanotic congenital heart disease lesions. And he has got a good collection of very interesting cyanotic and cyanotic congenital heart disease with him, which is going to share and show to all of you. Sir, it's all yours.
Okay. Can you hear my voice?
Yes, sir, we can hear your voice.
Sir. So as we have mentioned, the heading is common cyanotic heart diseases, because if you see cyanotic heart diseases, there are textbooks on common heart disease, on the text, this cyanotic heart diseases. But at least we want to see what you see during adult phases, because in infants we normally don't encourage all of you to learn that. Is the common what you see in the adult patient. Now, once you get a cyanosis, this cyanosis can be central. That is the usual cyanosis which we get. That is because of the right to left shunting. So when there is a mixture of the oxygenated and the unoxygenated blood, it, it tends to produce a central cyanosis, which is called, which we are not connected with that today. And differential also we are not able to see now because of early intervention. For example, sometimes you may cyanosis in the lower limbs and not in the upper limbs, like a patent ductus arteriosus with a pulmonary artery hypertension leading to reversal of the shunt, and sometimes cyanosis in the upper arms but not in the lower ones, like at EGA plus PDA. So, but you have, that is why we'll tell you why you want to see this cyanosis also, but we are mostly focusing on the central cyanosis. Now, there are certain nomenclatures when you read in the book also. One is the most common situs tolitus with levocardia. That means, remember LL, that means the cardiac apex is to the left and the structures are located in their normal positions, and the cardiac apex is usually on the left side, which is sinus situs tolitus and levocardia. Similarly, tachycardia is the cardiac apex to the right. When the heart is shifted to the right side, automatically the cardiac apex will come to the right. So that is the situs sort of levocardia and dextrocardia. And when sometimes you see situs inversus and dextrocardia, that means again the body organs are reversed and the apex is to the right. Similarly, situs inversus levocardia. Levocardia means apex is toward the left, but the abdominal and thoracic organs are reversed. That is, liver to the spleen to the right side, liver to the left side. So there's all a abdominal and thoracic structures are reversed, and apex to the left. But in a day-to-day practice in an adult patient, although we see for all the three things, but these two are the most common ones in these situations. So when you do that evaluation history, a clinical examination, but nowadays pulse oximeter is very important, because that is all about ECG, X-ray. Then we'll discuss about the saline contrast. But a pulse oximeter, you should always keep with you. Why? So because the integral cardiography helpful in mild cyanosis. So in this, use that is not when you see check in both, and the report value is always mentioned in the report that the oxygen saturation in the fingers is this much, dose is this much when you do any cyanotic congenital heart disease. So that is there. Now I don't know why, but now they recommend to use middle fingers instead of the index finger. So there are various other things. All you have seen the cyanosis clubbing, But this is important. Once you see these manifestations, that means that the child is very serious. Automatically you see a cyanotic manifestation differ from adults. For example, these are high risk patients. So that whenever you see any of these situations, always refer the child immediately to a pediatric cardiologist. And one is a poor feeding and failure to thrive. So this is one of the signs of an advanced cardiac problem and possibly heart failure, that the child is not able to gain weight and cannot take a poor feeding. Respiratory distress, when the tachypnea, the respiratory tachycardia, unexplained tachycardia with heart rate of 120, excessive perspiration. The mother tells that when the child is taking feed, he or she gets an excessive perspiration. When the child cries, there is an excessive perspiration. These are very serious signs in an infant, and they are indirect signs of a cardiac failure, and those should be, and these four are usually much more common, but you have to see all of these, and they require a high risk patient. So important point is if sedation is important. Say that is because you must have a good knowledge of anatomy. If you don't know what are the anatomical signs changes in that particular disease, you will not see for them. For example, suppose the fellow's tetralogy, there are four things in the fellow's tetralogy. So you must have a basic knowledge of the anatomy and physiology, that you must make a very short note of a basic anatomy and physiology, and a good knowledge of hemodynamics. Now, the sedation is usually, it is LA anxiety is easy to say but difficult to do. And when you are not able to, these children between the age, up to the age of 3.5 years, usually so the sedation dose is for 50 milligram per kilogram body weight. And remember, once you give a sedation, you must keep the child warm in any blanket or so. Not that once you have given the sedation, then you start removing the clothes and the child gets awake again. So remove the child's clothes. Number two, cover him with a blanket or a sheet, and then give a dry chloral with the pipettes or so that you can give a certain amount of cycloral. And then you have already told for a quick segmental approach has already been discussed with you. Always look for multiple lesions. Don't focus only on one lesion. Uh, in a congenital heart disease, always try to look for other associated lesions. Then, because you are seeing a central stenosis, you must demonstrate a right to left shunt. If you are not able to demonstrate right to left shunt, that means how can you get a cyanosis? So, good knowledge of anatomy and hemodynamics. If need be, give a patient a tricloral and quick segmental approach, what has been told to you when you were discussed about acyanotic heart disease, and always see for other lesions and must demonstrate a right to left shunt. And here the saline contrast echocardiography, despite the presence of a color Doppler, plays a significant role, and we are doing it quite a bit when we are stuck up as to what is the correct lesion. So what is the basic principle is you take ordinary glucose saline, you can take even a blood of the patient with a little bit of air, and you inject it through the arm to a white that cannula or so from the upper limb or so mostly. So this this syringe and this contains a certain amount of micro bubbles. When you take a glucose saline and you nicely you bring from one tube to another tube, one syringe to the tube, it produces a micro bubbles. And the technique is you take a large bore cannula in an anticubital vein, depending on the age, 5 milligrams, 9 ml of saline, 0.5 ml of air or so, or depending upon the age of the patient, and then you inject rapidly into the arm. So what happens? Now you see here, this is my left ventricle is always on the left side. Now, this is not a contrast. This is ordinary glucose saline. So this is always glucose saline, which has been very rapidly mixed from one syringe to another. So it produces a sort of a contrast effect. So this comes from the right atrium and then goes to the right ventricle. From the right ventricle, it will go to the pulmonary circulation. And because they are of a larger size, more than the RBCs, they get destroyed in the pulmonary circulation. So nothing is seen in pulmonary circulation. So you see, none of the left-sided structures are opacified. The LA is clean, the LV is clean, so that means there is no right to left shunt. So that is you see the glucose saline, agitated saline, goes into right ventricle, gets destroyed in pulmonary circulation, and then you get it, nothing in the left side. Now, suppose there is an atrial septal defect with a right to left shunt, then this contrast from the right atrium will come to the left atrium. That means it is right to left shunt. And similarly, in a ventricular septal defect, it will come from right ventricle to left ventricle. So depending upon the site of the shunt, and if it is a right to left shunt, because only right to left shunt will produce cyanotic accordingly. You see, now this is a parasternal long axis ventricular hypertrophy. Then this is the right ventricle, this is the left ventricle, this is aorta, and this is the interventricular septum, and this is supposed to be a interventricular septal defect. So in this patient, a marked right ventricular hypertrophy, it itself indicates that there is a significant through the defect into the left side and then goes into the aorta. So this is a right to left shunt because you have injected in the antecubital vein, it goes to the RA, then goes to the RV. Before going to the pulmonary circulation, it goes into the left side of the heart, left ventricle, and then it goes automatically goes into the aorta. So this is a right to left shunt at a ventricular level. Similarly, you see here, first focus on this side. This is left ventricle, right ventricle and large, right atrium and large, left atrium small, and a contrast has been given. Now you see here, when it goes from the right atrium, it goes to the left atrium, and this is free. So that means now the contrast is at the atrial level because the contrast goes to the right atrium, right ventricle, and then when it goes to the right atrium, it automatically goes into the left atrium. So that means it is the presence of a right to left shunt at atrial level. So we'll show you certain images more as and when they come. So they are some of the common that is the contrast is much helpful in these cases to delineate as to where is the shunt. So now we come to the most common one, that is a Fellow's tetralogy. Now, as I said, you must know the anatomical features. It is the commonest cyanotic heart disease in adults. Now, as we have told you before, the sequence of any examination in the heart is 2D anatomy, color flow mapping, Doppler features, and then associate lesions. Why? So this is like we have been telling you repeatedly that 2D echo, color flow, and Doppler. Color flow tells you which way the flow is going and to how to keep yourself parallel to the Doppler beam or so. So this is the sequence of examination in all adults and pediatric cases. Now, as I told you, you must know unless you know what are the features of an anatomy of this, you will not know what to see. So it is correct. Because it is known as Fallot tetralogy, so there are four things present in this. One is a ventricular septal defect, which can be seen in various views, but I have written that it is much better seen in parasternal long axis view. Then there is aortic override. We'll explain all the three things. There is an RVOT obstruction and right ventricular hypertrophy. But why there is a right ventricular hypertrophy is because there is an increased pressure in this when there is a pulmonary stenosis. Any stenosis or anything will lead to a proximal hypertrophy or so. And because the right ventricle empties itself into the pulmonary artery through the RVOT. So any obstruction there will increase the pressure. For example, suppose you take aortic stenosis. When there is an aortic valve is between the left ventricle and the aorta. So when there's aortic stenosis, more of the stress is put on the left ventricle because they have to push the blood through a narrow orifice, and as a result of it, the left ventricle's hypertrophy occurs. The same thing occurs in the pulmonary stenosis. The brunt of the stenosis is on the proximal chamber, that is the right ventricle. So there is a right ventricular hypertrophy. Now let us go to a normal thing. Now this is a normal parasternal long axis view. You see the left ventricle and the pericardium. On this side, this is the aorta with the aortic cusp and the left atrium. The point to note is that, as you have been told before, the anterior mitral leaflet is continuous with the posterior wall of the aorta, and the interventricular septum is continuous with the anterior wall of the aorta. So this is known as the normal mitral aortic and aortoseptal continuity, because both of them are maintaining the same thing also. So what will happen now, keeping this picture in mind, now you see, now here what do you see? This is the chamber. This is an aorta which is overriding the septum. As compared to this, now here you see the anterior wall of the aorta is in continuation with the interventricular septum. But here you see it is overriding the aorta, and you see, so that is known as those, what we see in these things. Number one, the presence of a right ventricular hypertrophy, the presence of a ventricular septal defect, and this is overriding of the aorta and dilated aorta. Sometimes it is also known as a biventricular origin of the aorta. Biventricular means the part of this, it is coming from the right ventricle and part of it is coming from the left ventricle. But I think override, and it should be more than about 50% of override in this situation. So I hope, again, if you see this picture, and you will clear to see the difference here. You see aortic or dilated aorta, aortic override, because they are anterior, which is here, posterior is here, and there is a right ventricular hypertrophy. So you have seen three anatomic features in the same scan plane. That means that there is a RV up to the pulmonary wall, and then it can be either, this is known as infundibulum, this is valvular, or they may combine. So the area up to the pulmonary wall is the infundibulum, and then it is the valvular lesion. The obstruction will be there at times, which is a very important feature of LOs, and that will decide the cyanosis. When we'll come to it, we show you again. So, so what you have, summary of the 2D findings: large, malaligned, non-restrictive VSD. Non-restrictive means, as you see, it is a large VSD, which is usually a non-restricted one. And because the smaller the VSD, the more restricted it is. Here it is a free flow from the left ventricle to the right ventricle. So it is known as an unrestricted also. So there is a large non-restrictive ESD, large aorta with aortic override, RV obstruction will show you, and right ventricular hypertrophy. These are the four features of a fallow color flow mapping. Now you see here, the color flow mapping type of the, it is biventricular, helps in localizing the RVOT obstruction. As you remember, any valvular disease or wherever there is a flow obstruction, there is a turbulence. So that it tells you from where the turbulence starts. And the turbulence always starts from the area of obstruction. In mitral stenosis, left ventricle, aortic stenosis, aorta. So it tells to the type of the shunt flow, localizing the obstruction. Will show you just now, and as usual, any Doppler study, it guides you parallel to the flow. Now you see here. Now this is again, you see this is a large ventricular septal defect, aortic override. Now see, the blue blood is going from the LV to RV because it is going towards the transducer. Red blood is going towards from the right ventricle to the left ventricle. So that means it is a bi-directional shunt. It goes from LV to RV and from RV to LV. So just have to see the color. The blue color is from the LV to RV because the transducer is pointing this side and this is on the right side. So if you see a Now here you see this is a still image. This is left coming the blue flow indicating the flow coming from the right ST. So this is a bidirectional shunt as you have seen here. Now coming to the RVOT obstruction. Now see, this is the most important hemodynamic determination. Why? The greater the obstruction, the greater the pressure of the RV, the higher the RV pressure, the more will be shunt from the RV to LV. Suppose there is a mild pulmonary stenosis, so sometimes there may be no shunt from RV to LV, and they used to call it as a pink fellow tetralogy. So the more severe the stenosis, as you know, the pulmonary stenosis, the major strain is on right ventricle because it tends to push the blood across the narrow orifice. So the higher the pressure, right to left shunt, both combined on this. So mostly you see
Sir,
here
voice is breaking.
infundibulum. Turbulence comes from the infundibulum, and infundibulum gets shut down also. And see the turbulence starts from here. So immediately the color tells us that is an infundibular stenosis. That is the point of origin of the turbulence. The point of origin of the turbulence is in from the pulmonary valve. So this is the pulmonary stenosis because it is coming from this, and it comes from the infundibulum because you see here this turbulence continues here, but its origin is here, though it continues beyond the pulmonary wall. You hear it is. So this is the types of the infundibular stenosis. We will show you further where the cases come also. And then Doppler features. Now, as you might have been told, the Doppler between left and right ventricular VSD indicates the pressure between the RV, LV, and the RV. The smaller the VSD, the more the pressure on in the left ventricle, the greater will be the flow velocity in the right ventricle. The larger the VSD, the less there's no restriction, so there'll be a low velocity flow. So here you see low velocity flow. Why? Because it's a free flow from the LV to RV, and you see this hardly any flow. Normally in VSD, small VSD, the flows are from 4 meters or 5 meters per second or so. But here, because it is a non-restrictive VSD, so the pressure in the left ventricle and right ventricle are almost same. So there is a very low velocity flow. So this is the reason for the low velocity flow, and hence we see it by a pulse Doppler. Here you see, although this is we have tried to use it as CW, but sometimes you can see even a pulse Doppler. But normally we take a CW. So in fellow tetralogy, as we have showed you, there is an aortic override. Number two, there is a VST with a right to left or a bidirectional shunt, RVOT obstruction, RVH, low velocity VSD flow, and turbulence in PA with a high velocity flow because of the RVOT obstruction. So whether it is a turbulence in PA or where at what level. So these are the signs of a fellow tetralogy which have been demonstrated to you. Now, in this case, you see this is the aortic override. You see the RVH is, we saw in the moving picture, there is a aortic override, large malaligned VST, and you see there is a bidirectional shunt, LV to RV and RV to LV, the blue flow. And so it is a fellow with a bidirectional shunt, and you see the turbulence starts in the pulmonary, the subinfundibular area. You see, this is the valve, and this turbulence starts in the infundibular area. So that means there is an infundibular stenosis. But sometimes you can see also whether there is a valvular and infundibular, sometimes by using a pulse Doppler here. Because this will record, a CW will record the whole velocity across the RVOT. So you can see this is the RVOT, and in the same patient, By slightly modifying view, you see this is the left atrium, right atrium, and you see the flow going from left atrium to right atrium. So this is associated is atrial septal defect. So that means beside the four lesions, another lesion has been added, and that is the ASD. So this becomes the Fallow's pentalogy. So instead of tetralogy, it becomes the pentalogy. So that means always examine all systems and see for any additional defect. If you would have missed this ASD, then you would have only labeled it as a Fallow tetralogy. And some of the method which actually I use is to take more anterior view, and the ASD becomes very clear. See. And one mistake is you can bring down this color. So because 0.64 is a high velocity flow, so because this is a low velocity flow, you can bring this scale down and you can see a better ASD. Now this is another case who came at 19-year-old boy with a case in a very serious state, multiple problems, and the cyanotic clubbing and the oxygen saturation was only 73%. And here, and as you see, here it is sign here the clubbing of the nails, and here it is central cyanosis. You see all the cyanosis and clubbing of the nails. Now, here you see the ECD shows the gross right ventricular hypertrophy. So this automatically tells you that there is a significant increase in the RV pressure and leading to a marked right ventricular hypertrophy. And you see here, this is the same patient. Now, what do you see in the parasternal long axis view? You can see significant RVH. And you see this is right ventricle. The right ventricle is enlarged in size, pushing the septum posteriorly with a small LV. And there is sort of an abnormal motion of the interventricular septum, which will be shown better in the M mode. So if you're asked to comment here, you can say right ventricular hypertrophy and RV is enlarged and the LV small. Now, same patient on an M mode echo, you see the IVS is about 12 millimeters, the RV. Always measure in diastole, never measure in systole. In diastole, the RV is about 12 millimeters, when the normal is less than 5 millimeters. So the same thing, whatever you put see in a 2D is reflected in the M mode. RVs enlarged, RVs enlarged, RVs enlarged here also. Now, this is sort of known as a paradoxical motion also, because here the diastole starts here, and here the diastole is here. Here the septum is, this is systole, here is systole is delayed. So you could very difficult to measure. So this out of phase motion of the IVS. Normally they move in the same place, but you see the here diastole is here, and here it is here. And systole is also delayed. So this is known as out of phase motion, and the RV is hypertrophic or so. The same patient you see, when you have been shown a pulmonary hypertension, one of the very classical signs is a D-shaped ventricle. This is RV, because normally the LV pressure is more than the RV. And that is why in a normal situation, the LV pushes the septum, and this is more of a convexity toward the right ventricle. But when the right ventricle pressure is increasing, it is pushing the septum back toward the LV. So this is known as flattening of the septum or a D-shaped septum. Always this sign indicates that there is a significant RV increase in RV pressure. And the same patient, when you go into short axis view, so this is the RVOT, this is the pulmonary wall, and you see an accessory membrane here. You see this is the obstructive membrane, which is obstruction going into the RVOT, and this is the pulmonary wall. And when you see in a moving picture, you see. So this is the RA, this is the tricuspid wall, this is the RV, significant RV hypertrophy, and this is the pulmonary wall, and this is a obstructing membrane into the RVOT. So we expect a turbulence to be at this level or so. So actually we have not shown there, but you see, we have seen there here, and you see there is a marked pulmonary stenosis. So that is was more of an infundibular stenosis with a triangular shape of this pulmonary flow or so. So there was a, so these are the three things, and here you see, uh, and then you see there's an atrial septal defect. So what this patient had, that means RVH, severe pulmonary stenosis, right to left shunt through an ASD. Earlier it was known as the triology of fellows. Triology means three things, but now it is known as the severe pulmonary stenosis with right to left shunt either through an ASD or through a PFO. So we have shown you tetralogy, we have shown you pentalogy, and we have shown you now triology also, but it is now known as the severe pulmonary stenosis, and with the RVH was seen, we have shown you, and the RV enlargement and right to left hand was shown as by a contrast echo. So now we come to another cases also. Say that is known as an Eisenmenger syndrome. Now it is also known as Eisenmenger reaction, Eisenmenger's complex, more common in young females also. So this was a 27-year-old female, dyspnea, cyanosis, and clubbing. And we showed you this picture before that marked RVH and RV is enlarged, and there is no aortic right, aortic override, but there is a large VSD, but there is no aortic override. And here you give a contrast, you see the flow. On a color flow pattern, it is mostly right to left, although there is some there, but mostly right to left. So that by this time, the diagnosis is a large VSD with the reversal of the shunt leading to cyanosis. So this is known as So this is Eisenmenger syndrome is it's a group of shunt lesions with severe pulmonary hypertension and increased pulmonary vessel resistance. So these are the common shunt lesions with severe pulmonary hypertension. Got with a PDA, they develop it at a younger age. Do have ASD, VSD at a younger age, and this is usually at the age of 25, 30 or so. So when you see a young lady with a severe cyanosis, with a bidirectional reversal of shunt, pulmonary artery hypertension, and once you have ruled out any other cause, then we call it an Eisenmenger syndrome or a disease because they have got a significant pulmonary artery hypertension and increased pulmonary vascular resistance. So these are the common ones also. And then, but before you have to rule out other causes before you see a primary pulmonary hypertension. But this is a different entity that when these lesions are present with a reversal of shunt, so this will produce a cyanosis of the lower limb and not of the upper limb or so. So this is known as an Eisenmenger syndrome. Now we come to TGA. Now there are things what is known as a concordance and discordance. Now concordance means when there is a normal connection. Discordance means when there is a abnormal connection. So we'll just now tell you what is concordance means a correct, and discordance means that there is a incorrect lesions also. For example, here the aorta rises entirely or apart from the right ventricle. So when it arises from the right ventricle, it is known as a ventriculo-arterial concordance. That means the ventricular-arterial discordance because it is coming from the aorta is coming from the right ventricle and the PA is arising from the left ventricle. So that is known as the transmission of great arteries. So there must be two separate and parallel circulations. If these two are remain this, the child can never live or so. For example, here you see in this circulation, the venous blood comes from the vena cava into RA. From the RA it comes to the RV. From RV it comes to the aorta, goes into systemic. So no person can survive with a continuous flow of a venous blood into the circulation. While a pulmonary vein is the oxygenated blood, comes to the LA, LV, and from the pulmonary artery goes to the lungs. So there are two separate circulations. One is an oxygenated blood, one is a venous blood. So there must be a sort of a shunt between any of the things, either ASD or a VSD or this. So for a child to survive, there should be some flow should be mixing also, not that only cyanotic blood is going and only oxygenated. So as we have mentioned here, some communication between them must exist to sustain life, like ASD, VSD, PAD, VSD in about 40 to 45% cases, and is a diagnostic emergency. So nowadays, what they do, If there is no shunt, they create a shunt in the eco lab by producing a ASD also. So this is a sort of a, a, a TGA. Now, so what is there? AV concord, that is atrioventricular concordant, that is atrium is connected to correctly to the ventricles, but there is a ventriculo-arterial discordance, that means the aorta rising from right ventricle and pulmonary artery rising from the left ventricle. So you must demonstrate an abnormal correction of these things also. And remember, remember that must have been told you, any great artery that does not bifurcate is usually the aorta, but a pulmonary artery is always bifurcating, and you take various views also. For example, you see here, this is a normal view again. And normally you see the aorta is usually directed toward the neck also, and that is why we form a suprasternal view. We always see the vessels also. And this is the LA also, and this. So the aorta is always going towards the aorta from the neck, towards the neck anteriorly. But here you see, this is an old case of Rakesh. You see here, this was, you can see the difference between that was done in 2003, almost 20 years back. So you see, this is one artery which is arising from the left ventricle, and we don't know what artery it is, but it is going posteriorly, and aorta goes anteriorly. Normally, it goes posteriorly also. So we have to show. So when you put a color on, you can see two branches. So one branch, one branch. So this shows that this is pulmonary artery, that it is arising from the left ventricle. Because here you can't see such good bifurcation, but here you see a good bifurcation. So must demonstrate a bifurcation. So from 2003, we come to, I think, 2020 now. Now this is which view? This is a subcostal view. This is a right ventricle. This is left ventricle. This is a VSD. As I told you, ASD, VSD is the most common lesion. Now this is a slightly modified view. We see one artery coming from the right ventricle, one artery coming from the left ventricle. Now we don't know which artery is which. So it can be so that is this artery. So we have obliterated the aorta almost so of this left atrial trauma, that we have focused only on the arteries. Now, when we put a color, we still don't know, because we are not able to show a bifurcation. This is left right ventricle, and the artery is coming from here, and this is the left ventricle from where an artery is coming here, but we don't know which artery is which. So slight modification of the transducer, we see a bifurcation. Now one branch go this side, one branch go this side. So this shows that it is a pulmonary artery, because it bifurcates and it is arising from the left ventricle. So that means the other artery which was coming was the aorta from the right ventricle, and this is the pulmonary one from the pulmonary coming from the left ventricle, and it shows a bifurcation. One goes here, one goes there. And you see, when you put a CW Doppler, there is a severe pulmonary stenosis. As you can see, there's a turbulence also. We see, when you see a turbulence, put a CW here, and there was a severe pulmonary stenosis with a velocity and gradient of about 105 or so. So this gives us the diagnosis. For example, again, the aorta, right ventricle, and this is the pulmonary artery which is coming from the, and you can see the pulmonary artery slightly thickened also, and this gives you a diagnosis of the transposition of the great artery. So you have to demonstrate that this comes this short X-ray view. You can see many other things, but we have just told you the common things also as to what you see, and the VST was present in this situation. So there is an atrioventricular concordance, there is a ventricular arterial discordance, demonstrate abnormal connection between ventricles and great vessels, LV connected to great artery that bifurcates in two branches, that is the pulmonary artery, RV great artery that does not bifurcate, that means it is in aorta. In a short X-ray view, although we have not shown you, there is a double circles of the aorta. In a normal view, you can see aorta pulmonary artery like a saucer shape, and we must demonstrate the presence of ASD, VSD, PDA And in these cases, we demonstrate the presence of a VSD. Makes you clear if it would have been an on flow in person, then I would have asked you that what that is show. Now you see here, there are situations when the RA is connected to LV. So that means there is an atrioventricular discordance, because normally left atrium is connected to the left ventricle, but here RA is connected to left ventricle. This is known as an atrioventricular discordance. Now here LA is connected to the right ventricle. Again, an atrioventricular discordance, and your pulmonary artery is coming from the left ventricle and aorta from the right ventricle. So we call it atrioventricular discordance and ventriculo-arterial discordance. So these are the four things which you can see. And here you see this is normal. I always should not show you normal. This is LV, this is RV, RA, and LA. So this is the normal contraction, this is the mitral valve, this is the tricuspid valve, and you remember any valve which is more toward the apical side is the tricuspid valve. Always, and tricuspid valve always is related to right ventricle. Remember, the tricuspid valve, and the valve which is more attached toward the apical side is always the tricuspid valve associated with the right ventricle. So they take a good, this is the tricuspid valve, because it is attached more toward the apical side. So this is the tricuspid valve, and this becomes the right ventricle. So this is what I know my now. See, this is the tricuspid valve, which is more attached to the apical side. So this is right ventricle. So what is this? Now we can see some pulmonary veins also going. So if this is the pulmonary vein, if we can demonstrate, so this becomes left atrium. So the left atrium is connected to the right ventricle, and the right atrium is connected to the left ventricle. So these are the examples of concordance and discordance. And you see here, you see now the pulmonary veins are coming. So this is one way of showing that this is the left ventricle, so that you see here. So even if without color, you can see pulmonary vein coming here and pulmonary veins coming here. So this becomes the left ventricle. So the left ventricle attached to the right ventricle, and you see here this thing, and you see this is the pulmonary artery is arising from the left ventricle, coming from the left discordance. They just not see many of these cases, but just to demonstrate the concordance or so. So you have seen both in these cases, you have seen RA connected to LV by this, because the mitral valve was this at the lower level, and LA connected to RV. So now we come to the Easton's malformation. Now there is no time to ask you questions. You can ask later on or so. What we'll show you everything what we born. Again, let us come to the a normal finding. Now this is normal. You see, in a normal individual, the tricuspid valve attached hardly about 5 to 10 millimeters more than the mitral valve. So this which is rising here, and this is rising here. So in the valve, and this is the mitral valve. In Easton, you see the septal leaflet is pushed marked anteriorly toward the RV. So instead of arising from here, it is normally arising from here. So there is a septal displacement of this septal leaflet and marked RA enlargement. So that is why they say that whenever an infant is born with a large cardiomegaly, think of an Easton's anomaly. So now coming further to see the distance about 26.5. Normally, it should be more than 8 millimeters per meter square, or sometimes the adults, it can be very near, about 15 millimeters also can be there as a normal variant. But here it is about 26.5. And instead of arising here, it arises here. So there is a marked apical displacement of the septal leaflet with about 26.5 millimeters. Now again, next is tricuspid dysplasia, that is enlarged anterior leaflet. Now you again come to the normal one. If you see the normal, this is anterior leaflet, this is the septal leaflet. This is small anterior leaflet coming like this. And now you see here, you see there is a large anterior leaflet like a sail-like motion. So this is again a sail-like motion of the anterior leaflet. And this is septal displacement of the tricuspid leaflet. And this is sail-like movement of the anterior leaflet. Again combined with this, here it is arising small a small anterior leaflet. Now here you see there is a significant enlargement and enlargement of the sail line. I like to see a sail in the of the ship in a same big floating tricuspid wall, anterior leaflet. Now, what is atrialization of the proximal portion of the right ventricle? So you have seen apical displacement, you have seen enlarged right ventricle. Now, what is atrialization of the proximal portion of the right ventricle? Now you see, now this is RA, this is RV. There's nothing, any structure in between. Any structure which is posterior or superior to the tricuspid wall is the right atrium. So this is the leaflets are here, and annulus is here. So this structure is the right atrium because it is connected superiorly away from the apex or so. Now, here you see what is happening. This the tricuspid leaflets are displaced. RV is divided into two parts. This
Voice is not coming.
between the tricuspid and mitral, hardly about 5 to 10 millimeters between the mitral and the tricuspid wall. That is the attachment of the tricuspid wall is toward the apical side. You can see here. So in this space anomaly, there is a marked displacement of the septal leaflet toward the attached very close to the mitral wall. But here you see there is a marked displacement of the septal leaflet towards the intervent toward the apical side, and the RA is dilated. Now, now you see this is about 26.5 millimeters. When in adults, it should be near about 15 or 8 millimeters per meter square if you take by the body surface area. But here it is significantly displaced. So the second thing is this a large left. You have seen the apical displacement tricuspid wall. Other is the enlarged anterior leaflet. You see here. Again, this is the normal patient. I'm always thinking a normal for the better in understanding of this is anterior leaflet. This is septal, this is anterior. Very small anterior leaflet coming from the right side, but in ephes normally you can see very large anterior leaflet. Again, compare. You see very small anterior leaflet here also, but here you see a large sail-like anterior leaflet, like you see a sail of a ship into the sea. You can see there is a lot. In this we see a marked septal and the shift of the septal leaflet, and you see this hard, large sail-like anterior leaflet. So now third is, so you have seen both. Third is atrialization of the proximal portion of the right ventricle. Now again coming to the normal, a right atrium is usually behind or superior to the tricuspid annulus. So these are the tricuspid leaflets which are attached to the tricuspid annulus, and any structure behind or superior to the tricuspid leaflets is the right atrium, and there is nothing in the right ventricle. Now here you see in a atrialized ventricle, there is a displacement of the leaflets. RV is divided into two parts. One is a true RV and one is a atrialized RV. And atrialized RV is because it acts electrically as a right ventricle and functionally as a right atrium, but you forget about it. And so any portion, any structure between the two leaflets is another the atrium. So this is known as atrialized portion of the right ventricle because it is a part of the right ventricle. So you see here, now see again, you see the same thing, nothing much in this, but here you see this portion between the anatomic tricuspid annulus and this is the functional annulus because the two leaflets are combined. So this is also part of the atrium. So this is known as atrialized right ventricle. It cannot be called as a right atrium because right atrium is the true right atrium, and because this is whole of the right ventricle, it is divided into two parts. One is true right ventricle and one is an atrialized right ventricle. This is known as between the two leaflets. So this is, you see, this is the anatomical. Here, this is tricuspid annulus. This is RV, and this is whole is the atrialized right ventricle. The larger that it is, the poorer the prognosis. Now, so you have seen three things: the tricuspid regurgitation coming from the apical origin. Whenever you see any regurgitation, forget about this talk. You see any regurgitation, you see two things. Number one is the point of origin of the tricuspid of the regurgitation, so that you don't miss any perforation of the valve also. So and you see the origin and then number of jets. Forget about it. So this is here you see in a normal individual, left ventricle, right ventricle, RA, LA, tricuspid wall, and you see the tricuspid wall, the jet coming from the tricuspid wall or tricuspid leaflet. So this is the normal tricuspid regurgitation, but here you see it is coming from the apex because the tricuspid leaflets are joining here. There's nothing here. So this is the apical tricuspid regurgitation. So there's an apical displacement tricuspid ring, anterior enlarged anterior leaflet, tricuspid regurgitation, and you see majority of them have got ASD or a PFO in 90% of the cases. And then there can be anatomical variants of the above. So you see here. So again, you see this ASD present, this is LA, this is the RA, ASD present. So the whole of the features are present of the Eastens or so. So apical displacement of septal leaflet, sail-like prominent anterior leaflet, atrialized right ventricle, PR coming from the apical side, ASD, BSD, PDA, all what we have seen and the increase in the RA. That is why they say that whenever you see a small child or infant born with a huge cardiomegaly, think of an Eastern anomaly, which is mainly formed by the two portions of the atria. Now we come to tricuspid atresia, another condition which you see fairly commonly in adult age. Now, remember, any structure which is absent is known as atresia, or any structure which is small and underdeveloped is known as hypoplasia. So absent is atresia, and that, as the name indicates, tricuspid should be absent, and our hypoplastic is small and underdeveloped. So in this patient condition, tricuspid wall is absent because it is atresia. RV is hypoplastic because it is small and underdeveloped because it is not getting blood directly from the right atrium. So it is because it is not being fed from the right atrium, hence it is small and isoplastic. The main chamber is left ventricle, which shows a compensatory enlargement. And there has to be a communication between the two RA, blind RA or like an ASD, BSD usually present. Why? You see this. Blood from the SVC, IVC comes to the right atrium. It cannot go to the right ventricle because there is atretic. So it has to go through an ASD to the left atrium. Otherwise, if there is no no ESD, then the patient cannot survive. So this is LA. LA is also getting a pulmonary venous blood. This mixture comes to the LV and goes to the aorta. But because some blood has to be oxygenated, so there is a shunt between the RV and the LV, which is LV and RV, which is hyperplastic, so that it goes into the pulmonary circulation. So that both ASD and the VSD could be present. You see again, normal, this is tricuspid wall, present, normal tricuspid wall. So that whenever you see an apical view, always see whether both the walls are present or not. And if they are present, their attachment is always normal. So see for attachment and their presence. Now you see, this is right atrium. There is no tricuspid wall. It is a shelf-like structure, blind structure. Then this is the hypoplastic right ventricle. Because ultimately the RV has to get blood from RA, but because it is not getting blood from RA, it is hypoplastic. So there has to be a shunt from the RA to the LA. Otherwise, patient cannot survive because blood cannot go on circulating only in the RA. RA not going anywhere else. The patient will not survive even for a minute or so. So from RA it goes to the LV, RA, LA, with the pulmonary veins, and then it goes to the left ventricle. With a single wall like this. Now see, this is your view, audience can plane. You keep LV on the right side, RV on this side. So you see, this is the RA, this is the LA, LV, a hyperplastic right ventricle, and complete absence of the tricuspid wall. So that is known as the tricuspid here. Now you see again you see, so you see when the pulmonary veins join, here the ASD is not there, pulmonary veins always connect into the LA, and here you see the pulmonary veins are coming, so this is LA. But you see, despite all these things, we are not seeing a right to left shunt. Despite a color flow mapping, we are not seeing any shunt from the RA to the LA. So that is we have to demonstrate that. So sometimes we give a contrast echo, and you see a contrast echo. It goes into the RA and then goes into the LA, LV, and then goes into the RVs. Now here, this is after few beats. You see, this is RA, LA, RA, LA, LV, and they see the small hyperplastic RV, so that you can now say that it is a definite communication and becomes a tricuspid atresia. Again, you see another patient. You see my view. We already. So you see, this is my view. You see, there is no ASD. There it looks as if interdigital septum is completely filled up. There's no ASD, and then it goes to the LA or the RV. And this is your view, where you keep LV on this side, RV on this side. You see, again you see the RA, which is enlarged. There is an station wall, hyperplastic right ventricle, absent of the tricuspid wall, and a single ventricle, and a single main ventricle. Now, so again now, so we have to again you see, there does not it leaves as if septum is intact. So what we do is now give a contrast, and you give a contrast. You see, goes into RA, LA, LV, and the ventricle. So it shows a both ASD and a VSD. RA is hyperplastic. RV is also opacified. And then you see for other associated features, there may be VSD. You see there is a parasternal long axis view, aorta, LRV, LV, interventricular septum, and you see a turbulence into the RV from the LV, indicative of a VSD. So absent tricuspid wall, hypoplastic RV, large LV, one prominent AV wall, ASD or a VSD, we have both have shown that any other associated lesions. So these are if you remember these pictures only, you will remember that you will never forget any particular a lesion if you go stepwise. Now, single ventricle, just I won't, because we see some cases, we'll show you just one of slide, what is single ventricle. All hearts with both atrioventricular connection in one main ventricular chamber. When there is a main one ventricular, which release blood from two AV walls, like a tricuspid mitral wall, it is receiving both tricuspid and mitral wall. As you see here, chamber, single AV, two AV walls kissing each other with no interventricular septal suppressing them, and so that in a single chamber having two AV walls. On a color flow mapping, you will see both flows coming into this and joining into the chamber. Nothing to separate them. See, the one AV wall, another AV wall. So both of them joining into the single ventricle, not obstructed by any VSD or so, or any interatrial septum. Both the walls are joining into one chamber. So that is single ventricle, and sometimes they are associated with a pulmonary stenosis. And actually, this was a child whom I saw first at the age of 7 years, and then I met him when he was 33 years of age. At that time, the surgery was not well demonstrated, well developed, and he had a pulmonary stenosis also. So that is the single chamber. Now this is the last one, but difficult one. Anomalous pulmonary venous connection. It's slightly difficult, but try to read it carefully. You will not find it any problem. It can be total. Even a total anomalous pulmonary venous connection is one, in which all pulmonary veins drain into the right atrium or any other chamber. But for your sake, you you remember right atrium, and majority of this the patient die in 1 year of life, and 80% die in the if left untreated. So a partial this, so there is marked enlargement on the right atrium. Why? The right atrium is receiving blood from the SVC, IVC, plus also the pulmonary veins draining into the right atrium. So there is an extra volume on the right atrium, like a volume overloading, and it leads to enlarged right atrium. And because there is increased right atrium, there will be increased right ventricle because more blood is going into this. A small LA, because the pulmonary veins are draining into the RA, not into the LA. So one is like a tricuspid atresia in which LV, RV was small. The small LA because the blood is going directly to this. This will show you a echo-free space behind LA and atrial septal defect. This. Now coming to this, again we come to the, so all four veins are not connected to LA. All veins join to form a venous channel. This channel joins to the RA to dip the blood also. Because it is very rare condition and experience is relatively small. Now you see this is this is RV, enlarged, RA enlarged, interatrial septum, small LA, and you see there is an echo-free space or echo-free chamber behind the LA. You see this is small LA, and you see this is a small chamber behind the LA known as venous confluence. You'll understand it better. Let me show you here. Now this is a normal case. RVRA normal, and you see there is nothing behind the LA. Pulmonary veins are draining into the LA. This is one pulmonary vein, this is second pulmonary vein. They are draining into the LA, and there is no chamber behind it. But here you see, this is a chamber which was not present in this, in this LA. But here you see there is a confluence or a channel, this one, which contains the pulmonary veins which go directly to the right atrium. And you see this is the atrial septal defect. As you see here, and this is again the subcostal view, RV, LA, small LA, large RV, and this is a venous channel behind the small LA. So again you see large RV, large RA, small LA, and a venous confluence. Now, see, now the blood in a color flow mapping, the blood goes from this is a venous channel, and from the venous channel it goes directly to the right atrium. right atrium, nothing goes into the left ventricle. So because it is not going into the LA is small, and you see a flow going into the RA producing large RA also. And this is the venous channel, which will show you again better. So what the surgeon does is he closes the ASD, and the connection in a communication between the pulmonary veins and the LA. So what he makes a pulmonary vein confluence and into the LA, he makes a connection and closes ASD. Now see here, enlarge RV, RA, and this is ASD. This is a chamber which is closed, and you can see that these are the suture lines also, and you see this is the venous channel. And this the surgeon has created a communication between the venous channel and the LA. The LA was small, and this is the venous confluence, venous channel, and he has created a communication so that now the blood can go from the venous confluent pulmonary vein to the left atrium or so. And you see here, you see now, these are the pulmonary veins and these are the venous channel. And from here it goes to the left atrium now. Nothing goes to the right atrium. And slight modification on the transducer. These are the pulmonary veins. They go into the venous channel here. So this is how it is this. So marked enlargement of right atrium, alveolar small LA, echo freeze behind the LA, and pulmonary veins not draining in LA but abnormal sites and atrial septal defect. So all the six things you have seen in that presentation, and it is suspect cyanosis and cardiac failure in infancy and unprominent cardiac murmur, large RV and a small LA with an ASD. So that is the thing, small LA with a small VSD. So this is large one, nothing special. Somebody gave me this slide that you see sometimes you have the value of the color is, this is short axis view, this is the aorta, this is the pulmonary artery, and there's an aortopulmonary window. Aortopulmonary window, you see there is a communication between the two. Here. In summary, always evaluate clinically ECG, X-ray, chest, or good sedation. Go stepwise. Always look for an RL right to left shunt either by color or a contrast echo. Try to see for multiple defects so that most important you must know what you are looking. If you don't know the anatomy, you will always miss it. A good sedation, stepwise, what I have been told to you during ASD or BSD.
थोड़ा बच्चों क्या चूक है वहाँ?
Always look for art shunt. So these are some of the basic things which we show you that. Am I heard now?
Thank you very much for being a part of this, being the only chairman of scientific committee and the real mind behind these programs. So I don't have to say like thanks since you are the part of
the person who executes is more important.
No. Brain
Advisors advise and then go to sleep, and the executioner has to work day and night.
Okay, sir. Thank you. And thank you very much for your deliberation. I hope people must have understand. I don't say everything, but at least a little bit of this congenital cyanotic
Some
heart
common things also.
Yes, sir. Thank you. Thank you very much.
Okay.
Good night, sir. Take care.
Good night, bye.
Be safe, sir.